Great, thanks for your nice, wonderful lectures. The final lecture is canceled, thus we are going to have a lot of discussion time until 20 minutes later. We got information from new devices such as Navitor Vision, Evolut FX VitaFlow, and Pascal Sapien M3 and Evoke for MR or TL. Do you have any comment from the panelists first? Dr. Kang, Kim, Park, Sung, Lee, Yang.
I have a question to Dr. Anurluk for the radial pulse of the VitaFlow. VitaFlow is not available in Korea, so we don't have experience. But we have a long time experience of Evolut series, and recently we have experience with Acrylic Neo. As we know that the Evolut series has enough radial force for the highly classified article. However, on the other hand, Acrylic Neo is relatively lower radial force compared to the Evolut series, right? So when you use the VitaFlow, so where is the level of radial pulse in between Evolut or Vita, or the stronger than the Evolut series? The radial pulse, in terms of radial pulse, please.
So the radius thing, I think for the VitaFlow, the company says that it's same as Evolut. But the Evolut skirt, when you face with the heavy calcify, sometimes it have the gap between the commissurer. When you have the calcium and calcium, so it have the gap in between. When you overexpansion, sometimes you do the post-dilatation, the AR is, the paraleak is more in some case with the cell expandable. So when you compare with the Acrylic Neo, is have the very radial strength at the annular contraction, because it have the radial strength of the Acrylic Neo is changed when it's not in the annular. The annular opening is have the radial strength as same as Evolut when the is in the node 1, but other part is less. So when you face the chunk of calcium, sometimes you cannot have a good expansion of the acrylic. But for the Evolut, you can expand, you can do the post-dilatation, but the calcium, you don't have any bulky skirt to seal it. So sometimes you have to think of Edward. VitaFlow is in between the Edward and Evolut. So I love that, because when you use this valve, it's quite guaranteed for the sealing property. One of the things that I always love this valve.
And then I'm sorry. In case of Acrylic Neo, is pre-ballooning is mandatory, right?
Yes.
However, in the Evolut series is case-by-case pre-ballooning, right? And then VitaFlow is, in case of VitaFlow, when you do the TAVR in highly calcified region, you mentioned that the radial pulse power is in between two known series, right? VitaFlow, and then we do a pre-ballooning mandatory or no in case of VitaFlow.
VitaFlow, sometimes you not necessary to do the pre-dilatation if it have less calcium. But with the heavy calcify, it's mandatory to do the pre-dilatation.
Let me change the subject regarding the 3 dots that is adopted by Evolut FX system as well as Navitor Vision system. Evolut FX adopted 3 dots, and they say it may help commissurer alignment, but I don't believe it, because the 3 dots start to separate only after we start deployment. If dots does not coincide with commissure, we have to recapture and rotate in a certain degree, but it is impossible. Which degree do we have to rotate? Thus, I don't think 3 dots in Evolut FX is not so helpful for commissure alignment. The similar situation happens in Navitor Vision. They also adopt 3 dots in the distal part, about 3 or 4.5 millimeters from the bottom. Thus, I have a question to Dr. Ken Zen. What's the purpose of 3 dots in navigator vision? Is it only for controlling depth and adjustment of coaxiality, or to avoid kind of oblique axis between valve versus ascending aorta? Or is it really helpful to adjust commissural alignment?
Thank you very much for the great question. I also think it is very important. In Japanese situation, some doctors try to adjust commissural alignment in navigator as well as evolutive system, but many doctors say that it seems impossible. So nowadays, most of the people give up that kind of maneuver in the system. I think that not the system, the vision system has clear visible marker on the bottom, and this is due to this is for the just only the adjusting the hips valve, I think.
I'd like to ask you, Dr. Leo. So, thank you for your lecture showing the future Edward transcatheter pipelines. And I was impressed by Pascal and EVOQUE. Pascal tricuspid and then EVOQUE also applied to the severe tricuspid regurgitation patient. There are a difference in indication of applying Pascal or the EVOQUE. So, can you explain the indication of each therapist?
Well, that is a fantastic question, and most likely question that will be asked for the years to come, because you're asking and wanting to understand that which patients would be better served with a repair technology and which would be better served with a replacement technology in tricuspid, knowing that these technologies have a very different risk-benefit profiles overall. And I think that right now we are still at the stage that the time will tell. Obviously, we know that there are some anatomical criteria that might be making a edge-to-edge repair therapy to be less suitable. For instance, if you have a wider coaptation gaps in between the leaflets, if you have a very rich chordal density that might be preventing one to place the devices appropriately, and then also knowing that with some of these patients, depending on what we might be perceiving their lifetime management to be, if they are younger, we know that an edge-to-edge therapy pretty much effectively shuts the door from the future interventions, like doing valve replacement, etc. So that's on the one side of the coin. Then the other side is with a replacement technology where we know that with a higher predictability and certainty, you will be eliminating the TR, but obviously the price that you pay is a larger amount of hardware. You know that all biological valves, prosthetic valves, irrespective whether they are aortic, mitral, or tricuspid, are destined to fail over time at some point. There is considerations around antithrombotic treatment, which is very different from on replacement technology as opposed to repair. So in the end of the day, there's multiple different considerations that will be playing a role in order to try to find the right place. And I would say that this discussion will be still ongoing for years in order to find what are the exactly the right patients for a replacement and which are for the repair. I'm sorry it was a long winding answer, but I hope it was maybe helpful to get maybe some insights where the things are at, and I hope that it answered the question in a satisfactory fashion as well as I can right now.
Thank you. And I'd like to ask you, Kanchen. So after I heard your lecture in Jeffrey Palmer's lecture, it looks like the Evolute FX and then Revito has similar performance in at the time of implantation. So you are experiencing both valve, and so what's your opinion about is there any difference between the Revito and Evolute FX?
No, thank you very much. I think there is a little bit difference between the FX and terms of the implantation technique. That's why due to the flexibility and softness of the shell. As I show you in my slide, when the valve enter inside the left ventricle, FX like one spine model shaft become more coaxial to the native noise. But on the other hand, the inhibitor's this tendency is more pronounced, especially in the horizontal animals. So as I presented as a second case, we should strongly, intentionally practice the navicular valve axis to the native annulus more upright position, because sometimes tips from the LCC become higher, and it may cause popping up phenomenon. So that is the very important difference between the effect and the system. So we should take care of that.
I think current difference between the Navitor and Evolute Pro, Navitor system is superior to Evolute Pro because softer, easily centralized, and less parallax, and very stable during deployment. But with the introduction of Evolute FX, both systems looks very similar. Thus, I guess the stability of Evolute FX will be significantly improved, like the level of Navitor system. Thus, I think the difference between two systems may be less with the introduction of Evolute FX.
I have a question to Dr. Kanjen about the Navitor system. Your case, almost all cases, post-dilatation was applied. So I think it's because of the radial force is weak than other valve. And then also there is the impact of power valve regurgitation will be more than other valve. And that is also related with the long-term durability problems. So what do you think about this? This is very important implication for the future plan. So what do you think about that?
Thank you very much. I don't perform the not for all of the cases post-dilatation. I perform the post-dilatation only for the mild, more than the mild to moderate PVL cases, right? And as you said, that the post-dilatation method may cause a problem in future the valve durability, but this is the trade-off between giving the mild to moderate, mild to moderate period and thinking about the long-term valve durability. Okay, so, but on the other hand, the pre-adaptation for the when the implants are several external valves are simply mandatory in Japan. For most of the cases, every physician tries to do the pre-adaptation to the native. That's the thing.
The expansile force between Navitor and Evolut is not so different. The reason why we more frequently perform post-ballooning is the structure of Navitor. It is intra-annular valve. But Evolut is supraannular valve. Even though annulus level, it is not round. Supraannular level, it more tends to be round. But in case of Navitor, it is just annular level. Thus, it is not fully inflated or became a round shape. The valve leaf-like coaptation may not be ideal. That's the reason why we more frequently do post-ballooning in case of Navitor, because it is intra-annular design. If there is certain degree of regurgitation, we have to be more aggressive. In terms of accurate, it is definitely weaker. Thus, even though it is supraannular design, we have to correct paravalvular leakage because it is weak expansile force. Thus, I think there is certain difference, the purpose of doing post-ballooning in Navitor and accurate. About percentage of post-ballooning in accurate is about 30. For my institute, about 50%. We do more aggressively post-ballooning.
I have one question. When it comes to radial force, especially radial force, which one is better between Navitor and accurate Evolut flex?
They say in the initial deployment process, the Evolut is strongest. But after complete deployment, the pressure against an annulus is not so different between Evolut and Navitor.
I'd like to ask to Dr. Ryo. So, you introduced the M3 for transcatheter mitral valve replacement. Recently, especially in Korea, in elderly people, the mitral annular calcification induced severe mitral stenosis. The population is increasing, but the treatment option is few. The surgery is very dangerous or no transcatheter therapy. So in the future, the M3 can be applied to such kind of MAC patient. So what do you think about that? So
Yeah, I mean that is for sure. It's an opportunity under investigation. We have, as a part of the Encircle trial that I mentioned, where we have finished the enrollment of the primary cohort, we also have an arm for the patients that have a severe mitral annular calcification as well. And it's under a certain circumstances for sure a technically feasible option, and the initial results what we have seen and observed thus far seem to be relatively favorable to it. Obviously, there's some limitations. You need to have the ability to circumnavigate the docking station in the valve, but from a sealing standpoint and all that, and from expansion standpoint, to create a sufficient valve opening area, all that seems to be extremely favorable. So I'm pretty confident that it will be a good and viable option for good selection and good proportion of patients with a calcific disease in mitral as well.
Also, I'd like to ask the procedural aspect of M3. The first step is wrapping around the mitral valve apparatus. It looks like very difficult. Edward already performed clinical trials. The doctors doing the M3 implantation suggest such procedural difficulty, or is very looks like difficult.
Yeah, yeah, Dr. Chang, you're alluding to obviously the most complex piece of the actual procedure, which is placing the duct and circumnavigating under the valve. Obviously, that's done currently under a fluoroscopic and echocardiographic control. That being said, we are currently working on doing some design iterations in order to make that to be easier and increasing and enhancing the ability how we can do that circumnavigation better going forward. So it's still a thing that improvements are needed. What we have experienced thus far is that there's variability. We see some of the cases going extremely fast, extremely well, where the placement of a docking station is just a hoot. But obviously we have experienced some challenges as well with that. So we have to put a lot of emphasis on the case support, on the appropriate training of the operators in order to acquire the skills needed for that as well. But we have good plans in place how to do that in a broad scale.
The hardest issue in this session is comparison between Sapien 3 Ultra versus Ablett Pro, or in the near future, Ablett FX is available. Thus, how do you think about the smart RCT panels? In small annulus, we all expect the orifice area is wider in Ablett system than Sapien. Thus, in a certain aspect, we can expect the results of a smart RCT. Even with this RCT, some guys insist the Sapien is good for small annulus patients, while another half of the physicians support Ablett system. How do you think about your opinion from Dr. Kang? Short answer. Is the results affecting your decision to choose between two valves in these small annulus patients? Dr. Kang? No? Dr. Kim?
Yeah, I think some trials show that valve deterioration is on the win for the self-expandable valve. Very small annulus area is like on the Sapien 3 20 millimeter. I think it is on the PPM or other issues. I think it will be better for use the self-expandable valve.
How about Dr. Yang? Yeah. Did these results affect your decision to choose valve between two?
Yes, I agree on the Dr. Kim's opinion. And here in Korea, we have a very small annula. It's below 400 or 350 in annular area. So in such a patient, Ablett valve is a better performance in hemodynamics, and even clinical outcome is better, I think. But there is no demonstrated result. In my case, with a very small annular area, I would like to implant Ablett less than Sapien.
How about Dr. Che? Short question. Ablett or
rather-
still Sapien?
It could be depends on the patient's situation, the anatomical and clinical profile, with limited longevity. I will rather use easy-to-use device, Edward.
Okay. How about Dr. John?
I expect future Sapien Ultra Regilia will be the enough competitor to Evolut system. But however, current Sapien Ultra cannot be the competitor of Evolut Pro or Evolut FX in patient with small annuli. That's the, especially in Korea, many patient has small annulus. So the several years follow-up shows the significant increase in the transvalvular gradient after Sapien system. So I have been the long-term supporter of Sapien valve. So as a fan, next Negelia system will be will eliminate this issue. I expect.
How about Dr. Park?
Yeah, from the beginning, the TAVI procedure, I prefer the supraannular type valve in case of the small annulus patients. So, yeah, I prefer the cervical valve.
Okay. How about Dr. Lee, Hanchu Lee?
My choice is Evolut, but I'm curious about Dr. Hyosu Kim. How about Nevito for small annulus?
I think it is not so different from the Sapien. In case of small annulus, I always prefer supraannular design. But when you see the smart RCT, I really suspect in terms of the good performance, good practice of Sapien TAVI, because AR incidence is greater than Evolut. It is opposite to our expectation or our experience. Yesterday, Didier is the PI of this trial. He mentioned he has a lot of experience with Sapien. Don't tell the high instance of AR after Sapien valve. But I guess there is certain problem of Sapien TAVI in their group. I suspect they perform Sapien implantation with just inappropriate oversizing proportion. They may deploy a Sapien just 0% oversizing or undersizing. Because they have a lot of experience with Sapien, they experience certain rupture cases, thus they adopt recessive, more conservative deployment strategy of Sapien. That may lead to AR more prevalent than Evolut and really high residual pressure gradient. That is the main driver of the loss of Sapien valve in comparison to Evolut in smart RCT. Thus, in my opinion, overall, small annulus patients, we prefer Evolut. But if Sapien is necessary, we don't forget about the full dilatation and achieve as wide effective orifice area as possible. That lead to less difference between two valves in even small annulus patients. Okay, and time's up. Thank you very much for 4 speakers and for our panelists. I conclude this session.